This is Doug Brunk for Global Medical News Network, reporting from the Summit in Aesthetic Medicine 2011 in Dana Point, California. Dr. Gordon Sasaki offered advice on when to retire or discard devices used for aesthetic plastic surgery.
Whenever we are dealing with technology, there is always going to be a problem with technology that becomes obsolescent. So technology will always move on, and what we obtain at one stage eventually becomes out of sync with new technology. So technology has limitations to it. It's a great investment. It does well, but eventually in time there'll be newer technologies that take its place. The second is that whenever you're dealing with technology, you're dealing with cost issues. And there are the upfront costs and there are the costs that you really do not see. One has to justify in one's practice the cost of the device and the return of investment. And many times there's a mismatch that occurs in practices where we obtain a certain type of technology and then that particular technology is still good, but it's not matching what our practice is delivering. The third is that many technologies have a human aspect to it. It not only involves the patient in the patient fatigue, the patient discomfort, but also the person who is administering, whether it be a doctor or it be a technician. There is going to be some fatigue with some of the devices. So those are usually the basic three reasons why certain technologies find themselves either becoming shared because of cost or becoming obsolescence and then they're discarded, or they are retired. They're still in our practices, but they are not the focal device for certain types of procedures.
During your talk, you mentioned that you replaced a high-frequency eradicator with a handheld, battery-powered cautery device. What led to that decision?
That decision was based primarily on a mismatch. As a plastic surgeon, I deal primarily with surgical procedures, even though we do have a large amount of non-surgical procedures. But when you're dealing with a heating device such as a hyfricator, there's a cost to it. And this particular device cannot be easily transported from one site to the other. In my particular patients, most of the lesions that I see can be easily taken care of with a handheld cautery, which is a heating device, which is much less expensive, and I can transport that from site to site. I think the main issue for me in discarding that particular device was that it became a mismatch. I just don't do enough of those kinds of procedures that particular device does well with.